Hi, good evening, everyone. Thank you very much for this opportunity, Sushmita ji. And today we are going to discuss a topic on trauma. Has been a matter of life and death when somebody goes through a severe traumatic injury. And the trauma can happen anytime. It's not just the bullet injury, or it is an injury to or blood injury, but there are various forms of, and we will see how trauma can present. Trauma patients can present. They may present in mass casualty. They may present as multiple casualties. And how do we sort out these patients and have a protocolized approach, following different protocols like ATLS principles, which we can follow up for trauma patients, and we will be able to really provide a comprehensive care to those patients. So, as far as the trauma assessment is concerned, so there are several ways to handle a trauma patient. So, it is very important that we should be notified about the trauma patients coming to us. Okay, so whenever you get a notification about trauma patients, so our preparation plan as to how to triage these patients and be well prepared to handle and take care of these patients. So it is very important that the life-threatening injuries are given priority rather than those patients who are creating nuisance and you know those patients who are absolutely awake, alert, and we address these patients. Rather than that, we address those patients who have a life-threatening injury, those who can die if we don't address that life-threatening injury. So we need to sort out these patients. And I'll tell you how do we sort out these patients. So whenever a notification comes that patients or we should prepare in the top in terms of preparation with administrative services, preparation in terms of assessing the resources that we have and sorting out those resources equitably to all those patients who really need indeed. Okay, so allotting those resources to those patients who are not very serious is not justified. So we should be able to do a resource allocation to those patients who are absolutely in need or those who have life-threatening injuries. And then we should do a primary survey and secondary survey. But what is important in trauma management is the resuscitation goes hand in hand while you assess the patient. So primary survey is nothing but assessment of the patient and sorting out these patients according to the severity, and we have to follow a proper A, B, C, D, E approach. And while we assess the patient, the resuscitation go hand in hand together. So we assess, but you don't resuscitate that patient promptly in due course of time. That injury, which may not be life, may lose. Resuscitation has to go hand in hand with the primary survey. And then at the primary survey is something which is very quick, and it has to be done immediately. And the primary survey gives emphasis to airway, breathing, circulation, and disability limitation. So so it doesn't need an institute. It can be done primary survey, or it can be done at the site where the hospital, bed, they have facilities to take care of airway, breathing, circulation. So primary survey is very quick, very immediate, and life-threatening injuries and those non-grievous injuries. And if your setup is not equipped enough to take cater that particular patient in terms of imaging facilities or in terms of laboratory services or in terms of availability of the surgeons or the doctors or the intensivist or the physician or the different surgical colleagues, if they are not available or empaneled in your hospital, it's better to transfer that patient. So we need to transfer that patient if we are not in a position to cater that patient and do justice to the ongoing injury that patient has suffered from. And if we can't salvage that patient, it is better that we transfer that patient to a definitive trauma center. So while we transfer this patient, it is very important where we transfer. Okay. So it is very important that we transfer the patient to a comprehensive trauma center. It should not be in a center where you don't have the facility available. Okay. So if you have a patient and you have a nursing home nearby and you have a comprehensive trauma center 50 kilometers away, instead of shifting that patient to a center where the facilities are not available, rather you will shift that patient to trauma center. You will be able to address the patient injuries very well. So it's very important that we transfer the patient to center which is capable enough to handle that patient. Like a patient, we send the patient to a neuro center. We have MI we send the patient to a comprehensive cardiac center. So similarly, a trauma patient has to be shifted to a comprehensive trauma center where injuries will be addressed immediately, especially those life-threatening injuries will be addressed immediately, and probably we will be able to support the patient dynamics, airway, and circulation is addressed immediately. And then, once the primary survey is done, secondary survey is a detailed examination of the patient. Sometimes the primary survey is done, in emergency or ER, and you don't have enough time to do a secondary survey, because if the patient has life-threatening injury which is identified in primary survey, the patient has to be wheeled inside the operating room and needs to be stabilized. We need to control the bleeding, and once the patient comes back from the operating room, the patient gets shifted to the ICU, and there we may do a secondary survey. So secondary survey is a very detailed examination where you do head-to-toe examination, and you take care of the patient's proper history, and you try to identify various parameters. And even if you have missed some injuries in primary survey, you try to address those injuries in secondary survey. Especially secondary survey usually done in ICUs. But sometimes if you have time in ER, while your primary survey is completed, if you have enough time before the patient is wheeled inside the OT, or for any imaging process, or before transfer to the definitive center, secondary survey can be done then and there. And probably those missing injuries which were missed in primary survey can be addressed in secondary survey. But secondary survey has done, it doesn't mean that you just stop resuscitation. We have to be continuously assessing this patient and resuscitating this patient hand to hand, and evaluation and re-evaluation is an ongoing process. And wait till we offer the definitive care. So the definitive care is in the form of addressing the life-threatening injuries and then sustaining those injuries to a normalcy. So that is how we do a definitive survey. So it is principles are based on initial assessment, which was primary survey. Which all before primary survey, we need to prepare the patient, and we should also be able to triage these patients quickly. To secondary survey, primary survey and resuscitation should go hand in hand together. Secondary survey resuscitation should go hand in hand together. And then whatever adjuncts are required, adjuncts may be in the form of imaging, X-ray, cervical spine, or X-ray, chest or pelvic X-ray, or insertion of lines, tubes, or insertion of Foley's catheter or Ryle's tube. These are some of the adjuncts that we do at the end of primary survey. And sometimes if it is not done in primary survey, we do it in the secondary survey. This is how the different phases of assessment of the trauma patient. In phase one, we triage the patient according to the severity of injury. The triaging is nothing but sorting out of the patients on the basis of the gravity of the injury that patient is suffering from. So only life-threatening injuries are addressed first, and then probably the less life-threatening injuries are addressed later.
Okay.
So the triage is definitely very important, especially when you want to address a large number of patients, especially with mass casualty or systemic casualty, when you number of patients, or your hospital, the capacity gets overwhelmed. So then you have to triage this patient, you sort out this patient. Only those patients who need threatening injuries to be handled immediately, these patients need to be addressed, and those patients with less life-threatening injuries, this can be handled later on. So triaging is important. And then you go for primary survey, research. So the secondary survey go hand in hand together. And if your center is not capable enough, you should have capacity to transfer that patient to a definitive transfer center. So definitive center from us. So these are injury timelines like for stroke. We give a timeline similar for these grievous injuries. If we address these injuries immediately, probably we will be able to save many lives. So first phase is injury prevention. Okay, the strategies should be, these strategies are advocated by government authorities and municipal corporation, and every various authorities. They strategize and make sure that the road is safe, or the scene remains safe. And you have also prevention and mitigation opportunities if at all there is any trauma or any casualty, mass casualty or systemic casualty. If you have, we have prevention and mitigation strategies to handle such situation. And once you have had a trauma, how do we sort out these patients and transfer to those definitive centers? Early hospital mobilization. So for that, your ambulances, ambulance services, healthcare, allied healthcare workers will need provide the initial aid to these patients. Transfer that patient to those hospitals. We have a rehabilitation facilities. Once you have stabilized the patient in a particular hospital, but if you don't have rehabilitation techniques, those rehabilitation services can also be offered. Have proper recovery and long-term disability care services. Rehabilitation services are also available. So these so sorry for these slides, which is a little blurred, and probably I'm also not able to see. But what are things that we need to be prepared when you get a pre-hospital notification? So when we get some news that you are going to 20 number of patients, some 20 number of patients coming to your hospital, which may be probably a mass casualty, or large number of patients are going to come to you. So our job in a hospital, is to notify the administration and make sure that the administration takes into account and strategize the overwhelming number of patients coming to the hospital. So how do we plan out? Okay, where do we keep these patients? So how do we sort out these patients? Where is the triage area? Where is the team that needs to be there while you have a mass casualty? So trauma is a multidisciplinary involvement where you need the involvement of emergency care physician, intensivists. You need surgeon, orthopedician, neurosurgeon, kind of vascular thoracic surgeon, and also need to notify blood bank for adequate blood and products, because if you have a mass casualty, large number of patients, and if any patient is bleeding profusely, so such patients may need transfusion protocol. So you need to activate blood bank and make sure that enough blood products are available, and time where you need rapid transfusions of large number of blood and blood products. The mass transfusion protocol also needs to be activated. And then it is very important that there should be an incidents command center where all the commands are given through throughout. Because if there are multiple people who are in decision making, then it will be like spoiling the broth. Too many cooks spoiling the broth. So that's why there should be one person who be leader, who is called as incidents command center and incidents commander, and he will give instructions to all the stakeholders, and he will be responsible for smooth treatment of these patients. And allocate the roles and responsibilities to various stakeholders. And then there are protocols which may not be placed or your hospital doesn't have protocols, so you will have to quickly set up the protocols to handle these patients. And you will also notify the imaging center, CT scan, X-ray, blood bank, operation theater also needs to be notified. And you also need to take the help of social workers, some allied healthcare workers who can take care of the families, grieving families, so that this media also, there may be a lot of media people around, and we need to handle the media well. So, majority of the hospitals, you will see whenever you have a mass casualty coming up, so you will also see the media people, coming around, and they will keep asking questions to multiple people. And then, if there are multiple messages being delivered there, then sometimes the wrong messages are also delivered, and and it gets circulated in the social media, and you will see the repercussions. And the large gathering you will be able to see in the hospital, and it is difficult to uh, you know mass the large number of people not suffering, but they are going to create chaos. So it is very important the handling of media and journalists and all these people is also very important, and give clear cut and clear cut message, and right message needs to be delivered, rather than creating confusion. So that was about pre-hospital preparation. And most of the times you see the team is not prepared, and even seemingly normal airway gets becomes very difficult, and intubation may be difficult. So airway preparation and monitoring and management is also very important, which I am going to talk about in my subsequent slide. So let's talk about different casualties like mass casualties. So mass casualty is nothing but large number of patients coming to you, overwhelmingly large number, where your hospital resources may be inadequate sometimes. So these mass casualty is something like, if your number of patients coming to the hospital is more than 10% of the capacity hospital, then you call it as mass casualty. So, for example, if you have a 500 bedded hospital, so if the number of patients is more than 10%, means more than 50 patients coming to your hospital straight away, then you call it as mass casualty. And you have to sort out these number of patients according to the severity of injury. So systemic casualty is another form of a casualty where the number of patients are less than mass casualties, less than 10% of the hospital capacity. Hospital is 50 bed, and even five patients coming to that hospital becomes mass casualty, and three, four patients coming to the hospital becomes a multiple casualty. So multiple casualty is less than the mass casualty, and mass casualty is something where the chaos sets in. So whenever you have a mass casualty, so it is very important that you have a planning. You have to analyze the potential problems that may happen. We need to also analyze the resources. We need to analyze how many blood bags we have, how many IV fluid bottles we have, how many different resources like plaster, cast, or so many things are available, or how many operation theaters are available to you for large number of surgeries to be carried out. So then that is how we need to assess the resources, and we need to also assign the roles and responsibilities while we handle the mass casualty. So, so how do we triage these patients? So we have to triage these patients based on the injuries that the patient may be. If the patient is walking, we can triage this patient and try to address later on. So, but if the patient has a breathing issue, okay, let's see if the patient is breathing. If the patient is breathing, means you can go ahead. If the patient is not breathing, check airway. And if the patient's airway is not patent, saturation is not recordable, and patient has no breathing movement, okay, so that patient is considered as dead, and that patient needs to be addressed, last. Okay, but if the patient has breathing difficulty and the respiratory rate is also very high, okay, so that is the kind of a patient where you need immediate intervention, and probably this patient may have a pneumothorax, hemothorax, and we ship that patient to a red alert area where the continuous ongoing resuscitation is required for that patient, and continuous monitoring is required. And if the patient's respiratory rate is high and capillary refill time is compromised, okay, that patient can, if the capillary refill time is less than 2 seconds, the patient goes to red area where immediate attention is required. But if the capillary refill time is more than 2 seconds, okay, that patient can be shifted to a yellow area where that patient is shifted, but needs to be addressed later on, immediately on immediate basis. So red area, immediate intervention is required. Yellow area is something where the patient has a severe injury but can be addressed later. And the patient who is walking, talking, and absolutely stable hemodynamically, that patient can be addressed later and shifted to the green area, and the dead patient can be addressed at last. And these are the different questions that we may ask while triaging the patient. The step one is to look at the patient's blood pressure, whether it is less than 90 systolic or GCS less than 14, or patient's respiratory rate is less than 20, less than 10 or more than 29. So that patient needs to be addressed immediately. But if the patient has penetrating injuries to the head, neck, or torso, or he has chest wall instability, or patient has crushed injury or degloving and suspected pelvic fracture or skull fracture, that patient needs to be addressed immediately and should be sent to comprehensive trauma center. But if the patient has a fall from 20 feet height, or if the patient has death in one, the passenger compartment, that patient can be addressed, to the nearby trauma center. That patient can be transferred, and has injuries which can be addressed later. We can prioritize the patients whose injuries are more grievous should be transferred quickly to the other centers. So as far as assessment, primary survey is the most important part of the assessment of the trauma patients. So primary survey is nothing but protocolized approach where we follow A, B, C, D, E approach. So where airway with cervical spine stabilization, it is almost always possible that whenever the patient's airway is compromised or injury to the head, the patient's cervical spine may be compromised. If we don't address cervical spine, the partial injury can convert into complete injury, and the patient may remain quadriplegic forever throughout the life. So that's why airway is always handled with cervical spine stabilization. And breathing. When you have addressed airway or enough oxygen saturation is maintained, we should go to B and assess breathing, how patient is breathing. And the patient's breathing is not comfortable, then every attempt should be there to provide some sort of airway devices, whether oropharyngeal airway or nasopharyngeal airway or LMA or definitive airway like intubation, or for some patients also may need tracheostomy, and maintain ventilation and make sure that the patient is on ventilator. So C is circulation with hemorrhage control. So when we assess circulation, so we need to try to control the hemorrhage. So hemorrhage control is resuscitation. In breathing, ventilation is resuscitation. In airway, cervical spine is also a form of a resuscitation. And D is disabilitation and neurological assessment, and make sure that the patient's neurological status is continuously assessed. If there is pupillary asymmetry, there is possibility of bleeding inside the brain, and that has to be addressed immediately. And at the end, you need to expose examination and try to address the bleeding areas and give compression, direct compression. Okay. So if the direct compression is the most definitive and most effective method to control the bleeding rather than applying dressings which may get soaked later on and the dressings may come out. So this is how we ABCD approach. So we need to see whether the patient's airway is compromised. So that patient needs to be positioned well. Okay, but the spinal motion should be restricted. That patient should be immobilized on spine board and make sure that the cervical collar is also applied. And if the airway is compromised, okay, saturation is low, it is very important that you cannot give Celix manure to the patient. You cannot give head, looking normal, but if you have to go for intubation, you can only give jaw thrust, and that will lead to difficult intubation. So very important that you should give only jaw thrust And if the patient has cervical spine, the patient needs to be manually stabilized, and cervical spine should be removed during intubation. And drug assisted intubation should be provided to these patients, where you give anesthetic agents which will provide quick anesthesia and good intubating conditions and intubate the patients. Okay, so that is about airway. Initially, we may try oropharyngeal, nasopharyngeal airway, but if the patient has CSF rhinorrhea, nasopharyngeal airway should not be attempted. Okay, oropharyngeal airway is given to those patients who are unconscious. Nasopharyngeal airway is provided to those patients who have airway handling is something which is very important, and maintenance of the saturation is very important, because if the saturation is not maintained, patient may die of hypoxemia, and the hypoxia is bad for the brain. So airway is always with stabilization of cervical. So make sure that the cervical spine is applied, and we need to feel for the cervical spine tenderness or any crepitus over there. And if there is any crepitus or injury, so make sure that the patient remain immobilized. Or and at the end of primary surgery, we may have to do X-ray cervical spine. But if the spine is free, if the patient's neck movements are free, patient is conscious, if the patient is able to speak, means patient's airway is patent and cervical spine is also normal, and you don't need to place a cervical collar. So while addressing respiratory failure or breathing, we need to look at three important parameters. We need to look at pneumothorax, hemothorax, and cardiac tamponade. For that, we need to probably do a POCUS examination, ultrasound, lung ultrasound will help you to identify pneumothorax. Pneumothorax will be seen as a barcode when you do lung ultrasound. Hemothorax will be, you will be able to see fluid collection in the thorax, and pericardial tamponade can be done, which will be seen as a collection in the pericardial space. If there is a pneumothorax, a tension pneumothorax, a needle decompression in the, fifth intercostal space is advocated. So, for children, we may have to do needle decompression in the second intercostal space and not in the fifth intercostal space. So earlier recommendations were like, we can do needle decompression in the second intercostal, needle decompression in the fifth intercostal space, and try to place a needle, tube thoracotomy. We should do a tube thoracotomy later on, because needle you cannot keep it for a long time. And if you have done a needle decompression, keep the sheath there. If you remove the needle, again there may be a recurrence of the pneumothorax, and the tension pneumothorax can get aggravated again. So whenever you have placed a needle for decompression, make sure that the ICD is placed, and you place ICD even for hemothorax. And if there is a massive hemothorax, try to drain hemothorax gradually. Don't try to decompress the hemothorax rapidly. That may cause hemodynamic compromise, negative pulmonary edema, and then patient may get exsanguinated immediately. So if there is excessive hemothorax coming up, more than 400 ml per hour or so, so probably this patient has major vascular injury, thoracic vascular injuries, and we need to, intervene, doing angiography, and, so, cardiovascular thoracic surgeon also needs to be involved. But if the while addressing C, the addressing C is circulation and hemorrhage control. So in hemorrhage control, we need to at least check the pulse, see the pulse, whether the pulse is feeble. If the pulse is feeble, so probably the patient's systolic blood pressure is less than 90. And also look at the capillary fill type, look at the tachycardia. And they, also collect sample for hemoglobin and blood group chromatin, and think about a fluorescence even, rather than cold crystalloids. The cold crystalloids can be problematic. So the warm crystalloids, pre-warmed crystalloids, balanced crystalloids at 20 ml per kg can be given rapidly. But the resuscitation crystalloid resuscitation will not be, overzealous, because that and this patient may need more for blood, should be transferred. We also need to look at the surfaces where the bleeding, the blood might have spilled. Okay, if there is a significant blood on the floor, and also look at the blood at the four areas: blood, brain, blood in the thorax, blood in the pelvis, and blood bleeding from the long bones. So these are the four areas that we have to scrutinize while handling circulation and patient has a hemorrhagic shock. And try to keep the blood pressure around 90 systolic. Don't try to chase normal blood pressure for a patient, for a trauma patient, because if you keep the blood pressure a little high, that patient is going to bleed more. Okay. Or if there is a temporal effect of a clot sitting on the bleeding, if the BP increases, the time will get discharged and the patient may bleed more profusely. So the dictum here is permissive hypotension. Okay, but this rule doesn't fit for traumatic brain injury and pregnant patients where you have to keep the mean arterial pressure more than 65. And for brain, you may have to keep a little higher blood pressure, keeping the cerebral auto regulation in consideration, and try to keep mean arterial pressure around 70, 75. So these are the important parameters, and give tranexamic acid is very helpful preventing the bleeding and the coagulation cascade that sets in. The plasminogen is considered to be plasminogen inhibition that happens during various or that are released, and then plasminogen and protein that will cause more bleeding. So, activate plasminogen acid is a good choice. So, in circulation, you have to look balance for blood. Okay. Whenever you're giving blood transfusions, probably one ratio of transfusion will be considered. One PRBC for one platelet and one FFP can be given to these patients. Okay. And when you look at the disability limitation, make sure that the patient is in head up position. If the patient has suspected brain injury, traumatic brain injury, okay, the intubation should be such that the intubation should not lead to any rise in intracranial pressure. And neurosurgical consult is very, very important in this patient. And if the patient has bleeding inside, all the measures to control the intracranial pressure should be advocated. 3% saline mannitol, and try to keep the mean arterial pressure a little higher. And every attempts advocated if the patient is having impending herniation, the patient should be built inside the operating room and should undergo decompression. And if the patient is in neurogenic shock, okay, so neurogenic shock will cause initial sudden elevation. This patient will vasoplasia due to exhaustion of the catecholamines, and the patient will become hypotensive. So that situation we may have to support with the vasopressors like norepinephrine, should be the first choice, and second choice. After the disability assessment, then go for is expose of the patients. Expose the patient and look for the bleeding areas, only bleeding areas. Okay, so while listening to the patient who get exposed to the environment, hypothermia. And please remember, hypothermia is a big culprit. Hypothermia and withdrawing the patient becomes acidotic. Hypothermia, acidosis causes a lethal triad. We call it as a coagulopathy, and these patients will bleed more. So that's why pre-warm crystalloids and cover the patient once the exposure is done. And the second, at the end of primary survey, two things we should do: one chest X-ray and one pelvic X-ray. But if the patient has cervical spine tenderness or injury, which is ruled out by nexus criteria, which I'm going to speak about in my next slide, cervical spine X-ray is not mandatory. But if the patient has suspected cervical spine injury, you can do cervical spine X-ray. And we need to place a Riles tube and Foley's catheter and monitor urine output hourly. And suck out if the patient has Riles tube. There is the aspiration, it has to be empty. It doesn't has to be empty completely. And secondary survey is usually done at the end of primary survey, where you need to take ample history. You need to ask for history of allergy, history of medications last patient must be taking. He may be taking beta blockers, he may be taking aspirin or anticoagulants, or if the patient has any past illnesses like diabetes or evaluation is very important, because if these are not evaluated, the patients can the missing injuries can be undermined. For example, if the patient is taking beta blocker, the tachycardic response may not be there. If the patient is taking aspirin, ecosprin, so no matter how much combination you give, the patient is likely to bleed. So you may have blood products probably in these patients. If the patient is on warfarin, okay, so you may have to use antidote or combined, antagonists can be given. So that's why it is very important. If the patient has diabetes, so patient diabetes, sugar, so that also needs to be assessed. And if the patient is on insulin or OHA, oral medication, the patient may develop hypoglycemia or hyperglycemia, which will be detrimental. And you also need to assess what when patient has taken last meal. That will help you to aspiration in the airway, or if the patient is drowsy, this patient may get very see the last meal. And we also need to see what were incidents and what are the events that have led to the grievous severity of injury. You need to look at what type of injury patient has, whether it is high velocity, or the patient has injuries which be causing a lot of physical harm to that patient, whether the patient has head injury, maxillofacial injury, chest or abdominal trauma, and then accordingly you can consider the injuries and evaluate the patient over a period. Has to be, overzealous fluid resuscitation should be avoided. And then we need to also look at the focused massive transfusion protocols, rather than just inadvertently a transfusion in these patients. Protocol then for then only probably we should transfuse of the platelet is less than 20,000, and the patient has risk of bleeding, then only transfusion is given. But if we are giving multiple transfusions, the transfusion should be given in 1:1 ratio. So basically, why? Because initially we used to get whole blood, but now you get blood and blood products. The different components are available, so that's why the blood product should be given in 1:1 ratio. So as far as the fluid resuscitation is concerned, pediatric patients also 20 kg of fluid should be given. And if the patient is not responsive to fluid resuscitation, further crystalloids can be given, but make sure that the blood is transfused rather than unnecessarily fluid transfusion. So as far as airway handling is concerned, rapid sequence intubation or drug assisted intubation is very important. So normal laryngoscopy sometimes becomes difficult. It is very important that we use video laryngoscope and have a non-traumatic intubation, because traumatic intubations can lead to more bleeding, and more bleeding in the airway can cause more aspiration. So that will be more traumatic. So that's why the intubation or airway handling should be done by the experienced, physician or anesthesiologist if it is available. So that is more important. And do not do harm. Rapid sequence is very pressure, but the cricoid pressure can be avoided if the patient is found to have cervical spine injury, because while you give cricoid pressure, that may cause if pressure on the cervical spine, and then if there is cervical spine fracture, that can cause more harm and patient may become quadriplegic. So very important to use these maneuvers very judiciously. So when the patient is in shock, we need to clarify the shock type of shock it is. So we need to define in terms of different phases of shock, whether it is class 1, class 2, or class 3, or class 4 shock. So class 1 is where you have a blood loss of less than 5%, and class 2 is when the blood loss is around 15 to 30. And class 3 is something where the blood loss is 30 to 40%, and class 4 is more than 40% of the blood loss. But in class 1 and class 2, you will not see much change in the hemodynamics or heart rate or blood pressure or pulse pressure or urine output, GC score or base deficit. So these parameters are not, compromised. But class 3 is one form of a phase of a shock where you will see the all the hemodynamic parameters being altered. Patient will have tachycardia, low blood pressure, pulse pressure will be widened, and the patient may be symptomatic with respiratory rate, tachypnea, tachycardia, and urine output will be compromised in these patients. So, and these patients will also have acidosis. The base deficit will be -6 to -10. So these patients need to be addressed immediately and should be continued ongoing resuscitation. Now, the class 4 is something where the patient has bled more than 40% and patient will be exsanguinated. Patient's pulse and breathing problem maybe not be, maybe very feeble or may not be recordable at times. Patient blood pressure, measurement also may be erroneous at times. So urine output will be definitely compromised and he will not be passing urine, and patient's base excess may be very much low, and basically this patient will need massive blood transfusion. Again, massive blood transfusion protocol needs to be active, like activate or for MI activate MI protocol. Similarly, for massive blood transfusion, we need to activate the protocol. We also take the blood and so mismatch transfusion will be likely to happen when when you rapidly try to transfuse the patient. So when in such cases where you're sure about the blood groups, O negative blood group can be given to these patients, and but later on the subsequent blood products should be O negative, and as far as possible, the group specific blood should be given to avoid RH incompatibility, and mismatched transfusion can lead to lethal complications, including death. So that's why very important to give blood products very judiciously, and the such patients are also develop transfusion associated lung injury, TRALI. So that's why this blood product should be given as is required. So so these patients also undergo abnormalities with the coagulopathy. So routine monitoring like bleeding time, clotting time may not be reliable in these patients. Even INR also may not be reliable. So we need to find out what sort of abnormality is so routine such investigation can be very helpful, and will give you pinpoint assessment of what problem, whether patient has platelet problem or patient has coagulation factor deficiency or patient has a DIC or coagulopathy is due to fibrin loss of clot. The fibrin degradation products are increasing. So that kind of information we will get it through thromboelastogram. And there are studies of acid at all, we have to give immediately first bolus within 10 minutes, and it has to be within 3 hours of injury. And later, injections can be given at dose 1 gram over a course, and studies have shown positive benefits of tranexamic acid. Let's see the individual traumas. Let's start with the thoracic trauma. So thoracic trauma is, grievous at times, especially when pleural chest or a tracheobronchial injury is there. So that has to be handled well with pain relief adequate, and oxygenation is very important. And if the patient has tension pneumothorax, needle decompression should be done. And if the patient has a tracheobronchial
Still, as per
injury,
the protocol dialysis, if you have a bradycardia, I think you're supposed to stop the dialysis for 2 hours, right?
okay, can we
Like
unmute?
47.
Can we
Just
mute
check
the
if the
audio,
patient on
please?
midazolam, we can stop the midazolam.
Sushmita, can you please mute the audience? Yeah.
Yes, sir, I've muted.
So basically, the chest drainage tube should be around 28 to 38 French, and not very large, large size of ICD. 28 to 32 French chest drain is sufficient. If there is, we should have algorithm for circulation approach. We should have algorithm for aortic, rupture, and it has to be handled well. Whenever we have a life-threatening injuries during primary survey, airway obstruction is one of the life-threatening injuries. Don't try to negotiate the foreign body if the patient has oral injury and there is a foreign body or tooth dislodged. Don't try to swipe the finger and try to remove it. Patient may bite or may lose a finger or they may be injured too. It is very important that while you assess the airway, we need to inspect the cavity properly. Use Maggie forceps and remove the foreign. Okay, if you try to swipe the finger blindly, that foreign body get dislodged further and partial obstruction may get converted into complete obstruction. So very important that you remove the foreign body under vision, especially with the laryngoscope, or if you are able to see the foreign body, magal forceps should be very, very important. So as far as this tension pneumothorax is concerned, E-fast is very important, and a tension pneumothorax can be seen as a barcode sign, but but you need to have a more learning curve, and it has to be done with repeated examinations. And if you have a good hands-on ultrasound and you are able to differentiate the pneumothorax with barcode sign, I think this is one of the important signs, because you cannot wait till the X-rays are done. Tension pneumothorax is a clinical diagnosis, and it has to be addressed with clinical examination, resonant note, and then E-fast can help you to identify pneumothorax quickly. And if there is a barcode sign, never hesitate to place a patient has extreme tachycardia, or now respiratory arrest kind of a situation is happening, and you have a barcode sign which is positive, please place a needle in the fifth intercostal space and drain the pneumothorax as far as possible, as early as possible. So as far as the management of circulatory arrest is concerned, so this circulatory arrest is usually seen in patients with tracheobronchial injury, or patient has a massive hemothorax, or patient has a thoracic aorta or arch of aorta or descending aorta injury. So in that situation, we need to see whether the patient is conscious or exsanguinated or not. Usually with such major aortic injuries, or major tracheobronchial injuries, the patient will be exsanguinated, patient will be arrested, and then this patient needs CPR. The CPR should be ongoing, such that if there is a injury to the heart, okay, or penetrating injury to the heart, so even your external cardiac massage may not be sufficient. So we may have to open up the chest, give a clamshell injury, clamshell incision on the chest, and give intracardiac massage. That is the most important form. So, but if the heart is intact, the intracardiac massage is important, good enough. But if there is a perforation or injury to the heart, so it is better to activate eCPR, where in eCPR we place the patient on ECMO, cannulate the femoral artery and femoral vein, and you can go with the peripheral ECMO or central ECMO and try to salvage the patient. And it is very important that you control the bleeding, and blood products should be involvement, where you need a thoracic surgeon, cardiac surgeon, you need massive transfusion protocols, you need vasopressor support, you need ECMO services, and then you need to keep communicating with the family in such occasions. And usually the deaths are very high. So sometimes it is very important, when you have to give massive transfusions, even your, wide bore cannulas may not be seen, especially when the patient is exsanguinated, where you are not able to see any, vein, and you cannot cannulate. So intraosseous, fluid resuscitation or intraosseous transfusion can be very rapid, and you can give rapid transfusions, maybe around 400 ml, 400 ml per minute or something like that. So massive, rapid fluid resuscitation route. And in aortic rupture patients, the goal should be to keep the heart rate less than 90. Okay, heart rate less than 80, and mean arterial pressure should be kept at around 60 to 70. And we can save the patient, because if you have a patient has tachycardia and aortic injury, these patients are likely to bleed more. And if you try to keep the blood pressure also very high, these patients are likely to bleed more. So that's why the target is moderate, blood pressure, moderate heart rate. So let's look at the abdominal and pelvic injury. Injury is associated with a significant blood of around 2 to 2.5 liter. If they, that's why we need to see what type of pelvic injury it is. If it is open book fracture or closed book fracture. Open book fracture, pelvis can accommodate large amount of fluid, 2 to 2.5 liter. Even entire blood volume can also be accommodated in the pelvis. Especially the bleeding happens. The bleeding happens through the pelvic plexuses, which which gets injured in a pelvic injury. So that's why massive transfusion protocol should be there, and early stabilization of the pelvis with a pelvic binder and repeat examination of the pelvis should be avoided. And in pelvic injury, it is customary and it is very important to identify urethral injury. If there is a blood, the means consider urethral injury and don't tempt. We need not tempt urethral catheterization. Instead, we should go for pelvic fractures. Surgical consult is very important. Application of pelvic binder is very important. If the pelvic binder is not available, we should wrap the pelvis with the towel, or bed sheet, and try to squeeze the pelvis, effect on the pelvis, and the bleeding can be controlled. And uh, so pelvic fracture and long bone fractures are notorious to cause significant bleeding. So long bone fractures can bleed like pelvic fracture.
Yes.
So long bone fracture like fracture femur, fracture neck femur, shaft femur can bleed around 1.5 to 2 liters. Pelvic fracture can bleed 2.5 to 3 or 4 liters also, depending upon what type of injury and where the injury is, open book or closed book fracture. So depending upon that, the patient usually with the pelvic fracture should undergo angioembolization, especially with the pelvic, the branches of the iliac arteries are also injured. So that's why angioembolization is also very important. And this patient may be immobilized. Certain setup, these patients may are likely to develop deep vein thrombosis. So IVC filter, preemptive IVC filter placement and prevention of pulmonary embolism can also be one of the thought process that we can think about. As far as the head trauma is concerned, the major emphasis is in maintenance of the systolic blood pressure of around more than 100, and try to keep the mean arterial pressure of around 90 to 110, and keep the cerebral perfusion pressure of more than 60. And if we can monitor ICP, the ICP should be around 5 to 15. And if we have intraparenchymal leads which we can apply, where we can monitor brain tissue oxygen saturation, and brain tissue oxygen saturation can be more than 15 millimeter, and try to keep the saturation of around more than 94%, unless proved otherwise, and try to keep the sodium up. Because if the patient has brain injury, there will be cerebral edema, and to counteract the cerebral edema, osmotherapy, mannitol or 3% saline can be used, and 3% saline is has a superiority over mannitol when we try to control the intracranial pressure. And then as far as if the patient is on anticoagulant therapy, we need to find out what anticoagulant patient was taking. If the patient was taking aspirin and the aspirin or clopidogrel, so platelet transfusion is sufficient. Platelet count more often. Is also not in acetate can also be given to these patients. Uh, but if the patient has a bleed, can be given. Prothrombin concentrates are given where you want to avoid excessive blood transfusions. So factor 7 concentrates can. If there is heparin, which has led to bleeding, so sulfate given, and we to monitor repeatedly. If the patient has received local and patient is bleeding more protein sulfate, and we have directly acting thrombin inhibitors like abiraterone. That is the reason for patients with this bleeding. Idarisumab can be given, and these patients can be benefited with these and antidotes rather than blood and blood. In brain injuries, routine seizure prophylaxis is not recommended, but if the patient has seizure, the seizure prophylaxis can be given for 7 days, and after that, patient needs to be monitored. As far as the spine and spinal cord trauma is considered, we need to immobilize the patient if we have a suspected cervical spine injury or thoracic or lumbar or sacral spine injury, and we need to identify what sort of motor involvement patient has, and you assess the injury, neural injury. Sometimes you may have a motor injury, which is different, it doesn't coordinate. So we need to assess the, neurotome and myotome properly, and the thorough neurological examination is very important. But, if the patient has a cervical spine, when do you suspect patient as having cervical spine injury? If you cannot clinically appreciate it, mechanism by years, if the patient has dangerous mechanism which led to injury, or the patient has anesthesia, or patient has from more than 1 meter or 5 stairs, motor vehicle injury at a high speed, or collision injury. So these are the instances where you need to protect the cervical spine injury. And we need to assess the patient whether the patient is able to rotate the neck actively up to 45 degrees left and right. There is no need to do radiography. But if the patient is not able to move the neck, then cervical spine X-ray is very important. So nexus criteria should be advocated to rule out cervical spine injury. If there is no posterior mid cervical spine tenderness, no evidence of intoxication, normal consciousness, patient is alert, no neurological deficit, no painful distracting injuries, no X-ray. Okay, so as far as musculoskeletal injuries are concerned, these are responsible for significant rhabdomyolysis and acute kidney injury. And these, musculoskeletal injury also may be associated with skin avulsion, and there may be a contamination of the wound, and that's why antibiotic prophylaxis may be given. That's why we need to find out what is the size of the wound. If the wound size is less than 1 centimeter, you don't need to give any antibiotic. But if the wound size is more than 1 centimeter, probably this patient needs antibiotic support. And also need to see whether patient has open fractures. If the patient has open fracture, even if the wound size is less than 1 centimeter, then we need to give antibiotic prophylaxis. Generally, first generation cephalosporin is sufficient, cefazolin is sufficient. But if the patient is allergic to penicillin, then clindamycin can be given. And if any of these is not possible, if the patient has gram-negative infection, suspected gram-negative coverage can be given with gentamicin. And if the patient has significant once a day onwards, if the patient has signs and symptoms of infection, then beta-lactam group of antibiotics like piperacillin, dalbavancin, which is a broad spectrum antibiotic which covers both gram-positive, gram-negative organisms, should be given. If the wound is 1 to 20 centimeter, we need to see how much tissue damage patient has and how much is the severity of the fracture, whether the fracture is comminuted. So these patients definitely need antibiotic, first or second generation cephalosporins. But if there is severe soft tissue damage or substantial contamination, straight away loading dose of antibiotic, which will cover both gram-negative and gram-positive organisms. So these antibiotics should be covered. But if the patient has, trauma and he had got exposed to soil, standing water, so these patients, unless proved otherwise, should receive, broad spectrum antibiotics, which will cover both gram-positive and gram-negative. Thermal injuries are also very common, which leads to burn ultimately, and the burn injury needs to be, measured in terms of how much is the burn percentage. We have a rule of 9, which can be followed up. And fluid resuscitation is important in these patients, and these are non-infectious, so you need not give antibiotic, but fluid resuscitation initially with that Parkland formula of 4 ml per kg initially, followed by 2 ml per kg, and later on 1 ml per kg. But overzealous fluid resuscitation should also be avoided in these patients, and then fluid resuscitation should be adjusted according to the urine output, where how much patient has. Okay. And then, as far as the pediatric trauma is concerned, needle thoracocentesis is still in second intercostal space. Crystalloid transfusion should be limited as far as possible, and we can follow pediatric emergency care network research criteria for doing for a CT head. So, as far as the transfusion protocol, the percentage of burn and give blood and blood product and fluid transfusion, which is in the 1:1:1 ratio, similar to adults in pediatric patients also. So as far as the transfer to definitive center is concerned, if at all we have a facility to do a CT scan or X-ray chest, we should do it. Especially when you have a patient who has a simple pneumothorax, you're transferring this patient with positive pressure ventilation. This patient's pneumothorax, simple pneumothorax may get converted into the tension pneumothorax. So that's why if the patient is being transported, it is better we place an ICT and transfer that patient. If the patient has neurological problem, okay, if the patient is obtunded, it is better to do a CT. And then if you don't have, even if you don't have neurosurgical consult, do a CT and identify what's the problem and notify it to the receiving center. The dictum here while transferring this patient is you do thorough primary survey, secondary survey if it is possible, and inform at the receiving end and give exact events, notification to the center receiving end. So you need to tell whatever the type of injury, what resuscitation you have advocated, what sort of injuries you have identified, and what injuries need to be addressed later on at the receiving hospital. So these are clear-cut communication that we have to do. So there is no role of a diagnostic peritoneal lavage nowadays, and it has been replaced by UHG fast. And while we transfer the patient, we need to follow S-bar criteria. We need to identify, protect patients' airway, breathing, circulation, and we also need to see patients who being transferred is identified well. You need to know and the nurse name and who are the nurse or the doctor accompanying the patient should be given appropriate instructions to monitor the patient's vitals and fluid resuscitation or any injuries which have not been handled. They should be given enough information about the patient's clinical condition, and also need to notify what all products or blood products you have given or what all medications you have given. All that it has to be notified, and all proper notes should be handed over to the receiving end. And then especially when we are airlifting the patient, if the patient has pneumothorax, simple pneumothorax, we need to place the ICD and then you transfer the patient, because while in air travel in transit, the pneumothorax can be catastrophic, and it will be devastating and life threatening. So when the patient is in ICU, these are important parameters that we need to look at: pulse rate, blood pressure, and ventilate. If the patient is on ventilator, low tidal volume, lung protective ventilation should be given. Oxygen saturation should be monitored, and frequent ABGs should be done for those patients who have grievous injuries, and focus ultrasonography, which will identify four quadrants of the abdomen: right hypochondrium, left hypochondrium, epigastrium, and pelvic area should be ruled out. Right hypochondrium for fluid in Madison's pouch, left hypochondrium for splenic injury, epigastrium for pericardial tamponade, and pelvic injury for rupture bladder or any urethral injury which has led to extravasation of blood in the peritoneum. So these are my important message. This was my important message through my slides, and sorry for exiting the session by. Okay, I think I had a poor network, probably intermittently, uh, but I think most of the times I was audible. So
Yes, sir.
sorry for that, and make
Oh,
sure
no,
that
it's okay.
internet is stable. Thank you everyone for this interaction and
And thank you, sir, very much.
listening. I know it was very fast. I know I had to cover the entire trauma in 1 hour. Was very Herculean task for me, and I tried to do the justice. Probably it may be helpful to you in your practice also, and for exam going students also. It may be helpful probably. My PowerPoint will be available, and you can refer my PowerPoint also later on. Thank you, everyone.